So good morning everybody. So for today we're going to talk about common foot and ankle problems. So I will start with the forefoot problems. For the forefoot, the deformity occur from the tip of the toe go until to the base of the metatarsal bones as shown in the pictures. The first disease we're going to talk about today we call Hallux valgus. The other names that we commonly use is bunions. Usually people know bunion more than Hallux valgus. Is likely to be medical terms. For the Hallux valgus, the deformity is occur because of the toe drifting on the lateral part of the foot as shown on the right side. You can see my pointer right here. You see the big toe usually straight up and then it can be deviate on the lateral side. Okay, why does it happen like that? Because of the muscle pulling. You can see on the lateral side of the big toe at the proximal phalanx, you see 1, 2, 3, 4, 5 ligament attachment from the muscle pulling to the lateral side, and only one muscle pull on the inner side or medial. Usually the force on the lateral usually win because they have more power. And this problem usually occur in the female, and from the incident we found 15 female per 1 male. So why does it happen? They have at least factors that can be explained. So the first one we call intrinsic factor. Okay, so most commonly present or represent for the intrinsic factor is genetic predispositions. We found mother can transmit this problem to their child, approximately correlated 85%. And then the other things that can occur during in the developmental process is round head of the metatarsal head. If the metatarsal head is round and narrow and small, it's likely tend to be drifting easily compared to the big metatarsal head. So some people born with the hyperligamental laxity, and some maybe have hypermobile of the first ray. Now you can see here. So we test the big toe, try to elevate the big toe up. You can see the difference from the index finger here and from the index finger there. You can see the big toe elevate into the sky. If it's more than 10 millimeter, we call hypermobile of the first ray. Okay, but some patients already have some inflammatory joint, or also have the cerebral palsy or flat foot deformity that can be aggravate this problem. Another things that can be occur and it develop later on, we call extrinsic factors. The common thing that we have seen is the high heel and narrow toe box shoe. You can see on the left hand side picture. Look into the x-ray, you can see the bone deviate on the lateral side because of the shoe was molding that foot to deviate that way. If you use the narrow toe box for many years, the ligament on the inner part, we call medial collateral ligament, become insufficiency, and then they will develop the Hallux valgus. Yes, the clinical appearance, how you diagnose the Hallux valgus. You can see they have a small bump. They have the big toe deviated. And this stage, we return to the next stage. The big toe will be start to kicking the second toe and push it elevated into the sky. If you don't do anything, the third toe, the fourth toe will be affected as well. For diagnosis, after we see the patient with the clinical picture as I shown in the previous slide, we usually measure the angle from the x-ray. The commonly used angle we call Hallux valgus angle. So we're using the axis of the proximal phalanx an axis on the metatarsal bone. So this angle, this line, and this line, we call Hallux valgus angle, usually less than 15 degrees. But if you have more than 15 degrees, we call Hallux valgus. They have mild, they have moderate, and they have severe, based on the measurement angle that you can measure. Another angle we call intermetatarsal angle, or IMA angle. We measure the axis of the first metatarsal bone and axis on the second metatarsal bone. If this angle more than 9 degrees, we call Hallux valgus. They have mild, moderate, and severe as well. And another thing, that's the angle that we use for classify the patients and make for the plan of treatment. So when we establish diagnosis for Hallux valgus for the patients, the next step is we should know how we take care of them. We usually start with the conservative management, including a shoe modification. If you remember, narrow toe box, high heel shoe aggravate this problem or can be an extrinsic cause of Hallux valgus. You should be avoid or stop using that kind of shoe. You need to wear wide toe box. This is we call toe box. It is space for the toe. Another thing that we commonly use, we call toe spacer, which is separate between the big toe and the second toe as shown in the picture on the right hand side. And sometimes they have the silicone gel pad on the medial side of the big toe at the medial eminence of the bunions, which is help protect or prevent irritation from the shoe to the bunions. Patients usually have less pain. So this type of orthosis doesn't fix the problem, but it helps for pain. We can say pain improvement, and sometimes it can delay the process of the stage as shown in the picture earlier. So this is the first line of treatment, and some patients, they may have underlying of the gastrocnemius contracture or flat foot deformity. If you have gastrocnemius contracture, you may need to do stretching exercise of Achilles tendons. If they have flat foot deformity, you may need to prescribe an insole with arch support for them. That will be helpful as well. If you try to use conservative management for at least 6 months, but the patient still have pain and doesn't get better, and the deformity is still ongoing, so the next step will be surgery. Okay, for surgery, in the past we used the soft tissue procedure for the patient with mild deformity, but when we follow the patient in the longer operative times, for example 5 years, 10 years, we found that the patient have recur of the deformity, and now we know only ligament procedure is not adequate for the patient. You usually need to be combined between the bony work and the soft tissue procedure. So for the commonly procedure, we usually start with the gastrocnemius lengthening if the patient have Achilles tendon contracture and fail after stretching exercise. And then for the Hallux valgus itself, we will start with the lateral soft tissue release. If you remember the picture that I showed you, that they have multiple ligament and tendon attached to the proximal phalanx base. After we cut this tendon, you follow my pointer here. And then we shift the pulling from the proximal base to go down to the metatarsal head. So this will help to decrease the IMA angle, intermetatarsal angle, because the pulling right here. And then it decreases the Hallux valgus angle because we cut down, and then they have no force to pulling on the big toe. The second thing, after we do this one, so we usually do the bunionectomy, cut at the bump, and then the toe still deviated, we need to be cut the bone. We call osteotomy. For the small degree, we usually do a distal osteotomy. It means osteotomy on the distal part of the metatarsal bone. If the patient have more deformity, we're going to do a proximal osteotomy. Here's the concept for osteotomy of the toes. And then after we perform and the alignment may not be satisfied, we may need to add on the osteotomy on the proximal phalanx we call aching osteotomy. And here's the commonly used osteotomy for the hallux valgus. They have special cases that the patient have hypermobile of the first ray, as we shown in the picture. You may need to do the fusion of the first or the tarsal-metatarsal joint to make it rock and solid and stable. Okay, instead of do osteotomy, you're gonna switch from osteotomy to do fusion at the first TMT joint. Okay, and the other procedure will be the same thing. Okay, here's the picture before the surgery and after the surgery. This is an example for the proximal osteotomy for the severe hallux valgus. If mild deformity or moderate deformity, you can do this chevron osteotomy as shown in the picture. And here's the picture of the aching osteotomy. We do the proximal phalanx for the fine-tune, make the bone perfectly well aligned. Okay, here's an example of the real patients. You can see here they have a severe hallux valgus, and you can see the second toe we call hammer toe right here. Okay, we do the lapidus fusion of the first tarsal-metatarsal joint, we call lapidus fusion. We do bunionectomy, okay, and then we do lateral soft tissue release. In this case, we do the IP joint fusion for fix the hammer toe and the plantar plate repair. Okay, here's the first one. The second one, a bunionect or tailor bunions. It is exactly the same thing, but happen on the fifth toe. You can see they have the angle to measure between the intermetatarsal angle between the fifth one and the fourth one. If it's more than 8 degrees, so we can call the patient have the bunionect. Okay, and then the MTP angle, metatarsophalangeal angle, more than 14 degrees. It's similar to the hallux valgus angle, but it's measured on the fifth toe. This is will be indicated the bunionect. Okay, the treatment will be the same thing. So the patient usually start with the shoe modification and then the silicone gel pad on the fifth toe, similar to the hallux valgus, but this thing need to be put on the fifth toe. And then we can try this for 6 months. If it doesn't work, so the bunionectomy and osteotomy is indicated.